Ladies and gentlemen, thank you for standing by. Welcome to today's webcast entitled Survivorship, Guidance and Insurance for the Long-Haul Post-Transplant. If anyone should require operator assistance, please press star zero on your telephone keypad. A question and answer session will follow the formal presentation. You may ask a question at any time by typing it into the Ask a Question feature on your screen. As a reminder, this conference is being recorded. It's now my pleasure to turn the call over to Jennifer Gillette. Please go ahead.
Thank you, Kevin. Pleasure to have you all here today. And sorry, starting a couple minutes late. We had a little technical difficulty, but I thank you for your patience, and I'm so glad you're here. I think you're going to get a lot of wonderful information from our presenters today. So yes, we will be discussing the challenges and strategies for survivorship. Just so everyone knows, today we're going to have a brief little introduction to the National Bone Marrow Transplant link for those who might not be familiar with us. And then we will hear from Dr. Debra Friedman. She'll be talking a general overview of survivorship. Terese Roob will also be speaking. She is a survivor and a patient voice and just full of wonderful tips and ways that she coped with her journey. And then we also have Dr. Carrie Kitko, who will be delving in a little deeper into some of the survivorship topics, especially GVHD. And then myself, I'm going to give you some tips on dealing with fatigue, which affects the majority of cancer patients, and then we'll follow it up with a question and answer period. So for those who are not familiar with the National Bone Marrow Transplant link, we're dedicated to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources, support, and education. We link you to experts across the country in all topics related to transplant and to others who have made it through the journey before you. On the side here, we have Peggy Burkhart, who is our executive director, and there's also my contact information there as well. Some of the resources we offer are we have our Lunch and Learn programs monthly. We have podcasts with over about 25,000 downloads right now on a variety of topics. We have multiple webinars like the one you're on today, blogs from those who have been through the transplant process on a variety of topics, and all things related to transplant, including disease-specific information, survivorship issues, coping, and symptom management. We have a wonderful peer support mentor program for patients, caregivers, and we even have some donors too. We have our second birthdays recognition program because once you've had a transplant, you get 2 birthdays a year. And we have some great resources, books, materials, emotional support, and referrals. So if you need some extra support, reach out. And we also have our Facebook page, which you can go on for daily inspiration. A special thanks to our webinar event sponsors. This is the Leukemia and Lymphoma Society, Omeros, and our esteemed link partners for which we couldn't do any of these programs. So thank you so much. As a reminder today, before we get started, anything you hear today is to stimulate conversation with you and your healthcare team, but this is not meant as personal medical advice. So the first speaker we'll have today, we are so honored to have Dr. Friedman. She is the director of the Division of Pediatric Hematology Oncology, a professor of pediatrics and medicine for hematology oncology, East Bronson Ingram Chair in Pediatric Oncology, Associate Director for Community Science and Health Outcomes at Vanderbilt-Ingram Cancer Center. She is internationally recognized in research in cancer care, delivery, prevention, control, outcomes, and pediatric and adolescent young adult oncology. She has leadership roles in multiple committees in the Children's Oncology Group, and she is an inaugural member of the National Comprehensive Cancer Network Survivorship Panel. She has ongoing research funded by the National Cancer Institute and multiple foundations in cancer care delivery, survivorship, and health outcomes. Then we will hear from Terese Roob. again, a survivor. And I can survive her. She is so positive. I just adore her. She is very happily married, a 57-year-old woman for 34 wonderful years. She's a proud mother of 2 amazing adult children and blessed Nana to 1 grandbaby so far, a Colorado girl since 1995. She's an educator by nature and nurture with an undergrad in human development and family studies psychology, a master's in education, and focused on gifted and talented differentiated instruction. She has followed her passion for the last 22 years and thrived in elementary classrooms, supported gifted and talented students from 6th to 12th grade, and coached middle high school students to improve their executive function skills. She's an avid reader, a passionate cook, outdoor explorer, enthusiastic Colorado Avalanche hockey fan, and a lifelong learner. She is still in the season of strength and stamina building and has been for the past 17 months after receiving a life-saving stem cell transplant in May of 2022 for a life-changing atypical CML diagnosis in December of 21. She is a survivor committed to not wasting their cancer and living a thankful, grateful, and blessed new normal. I am sure you will be inspired. And of course, we are also honored to have Dr. Carrie Kitko with us, an associate professor of pediatrics, medical director, pediatric stem cell transplantation program, and Ingram professor of pediatric oncology. Dr. Kitko joined the Vanderbilt Pediatric Hematology Oncology program as the medical director of the pediatric stem cell transplant in 2015. She had previously worked at the University of Michigan, initially as a clinical fellow in 2003, and then was appointed a lecturer position in 2006 and promoted to assistant professor in 2009. During her time at Michigan, she developed a clinical and translational research focus in graft versus host disease. She has concentrated her research focus on GVHD diagnosis, treatment, and prevention. She is currently serving as the co-chair of the GVHD Working Committee of the Center for International Blood and Marrow Transplant Research. She has been serving as the chair of the GVHD Strategy Group for the Pediatric Transplantation and Cellular Therapy Consortium. At Vanderbilt, Dr. Kitko serves as the lead investigator for the Mount Sinai Acute GVHD International Consortium. This consortium has furthered GVHD biomarker discovery and has brought innovative clinical trials to our patients that allow for biomarker-directed GVHD prevention and treatment. Recently, Dr. Kitko led working group of the NIH Consensus Development Project on criteria for clinical trials in chronic graft versus host disease. The 2020 Clinical Implementation and Early Diagnosis Working Group report that was published in the Journal for Transplantation and Cellular Therapy last year. So as you can see, we have some amazing speakers. And then there is myself, Jennifer Gillette. I am the staff social worker at the National Bone Marrow Transplant Link, and I provide counseling in my hometown in Michigan. I've had over 25 years of oncology social work practice and counseling experience. And I've helped clients with a variety of life changes with all types of cancer diagnoses. I've been at the National Bone Marrow Transplant Link since 2016, and I've helped support people who have experienced a bone marrow transplant. I received my master's in social work from Wayne State University, and I spent 20 years leading the psychosocial support program for oncology over Providence Hospital and Providence Novi Hospital. I've provided private counseling, led support groups, assisted with educating patients, developed patient programming, assisted with research projects, and led the Fellows Clinic as a place for people to receive cancer treatment who had no insurance and were in socioeconomic crisis. At the National Bone Marrow Transplant Link, I'm available to help you with emotional support, resources, and supportive programming like you are on today. Okay, and so now, without further ado, Dr. Friedman, thanks for being with us. Dr. Friedman, are you on mute?
It's a pleasure to be here today. Thank you so much for the invitation to present. I will be talking a little bit, just giving an overview of some of the considerations following stem cell transplant. So when we think about the word survivor, it has many, many connotations. And truly, you know, when you've had cancer or have had a stem cell transplant for a non-malignant disorder, you are truly a survivor from the day of diagnosis moving forward. And as a survivor, you're going to experience lots of pieces of the medical system, and that's kind of the inner part of this circle here, where you will be basically seeing primary care, and you'll have survivorship needs. There'll be mental health needs. There may be different types of oncologists, different types of surgeons. There may be the need for genetics. And all of that comes together. And at the same time, there's a lot of other things going on. You may be part of support groups. You may participate in clinical trials that will be following. There are social needs. There may be specialty products. There may be rehabilitation services, etc. So I'm just going to really give an overview of what survivorship looks like in very broad strokes, just to help guide the path. So really, when we think about survivorship in the post-treatment phase, so following curative stem cell transplant, we think about it in kind of three buckets. We think about it in terms of prevention, and that is really for our survivors as well as kind of family members. So leading a healthy lifestyle, participating in physical activity, having an appropriate diet, not smoking, limiting alcohol consumption, and other similar lifestyle changes. The kind of other piece of this is really kind of detection, right? Early detection, not only for recurrence of your cancer that you were initially treated for or of a condition that you were treated for, but also adherence to follow-up care, screening for subsequent malignancies in addition to recurrence, and also screening for related comorbid conditions. And family members fall into that because there may be a genetic predisposition to the disease or a cancer that you were treated for and had a transplant for. So family members may also have specific screening that they need to follow. And then there's treatment and management of side effects. Obviously, there are lots of side effects during transplant, but late effects of cancer, its treatment, and transplant. And that can include things like pain and cognitive function, sleep disturbance and fatigue, sexual function, as well as really organ function. And families are really another essential part of this because generally families are providing extra caregiving and psychosocial support. So we need to be cognizant that they can also experience burnout during this period of time. This really looks at the survivorship issues from different perspectives. So, you know, for the patient, it is important, you know, to think about all the host components that are brought to transplant. For the provider, it's all about learning about survivorship, knowing about the needs of survivors, and being able to work together with survivors as well as other health professionals. Cancer brings its own special piece to survivorship in terms of the type of cancer you had, the type of treatment you had, and any complications you might have had up to that point. And then there's the whole healthcare system, just navigating through the healthcare system, which I will argue is absolutely not trivial or easy, who to see for what, how to appointments together, and importantly, how to get healthcare providers to talk to one another. When we think about the long-term effects of treatment, we kind of think about them in buckets. So one, I think about growth and development. So for children, this can involve linear growth, right? If they undergo a stem cell transplant or cancer treatment as a young child. But even as adults, there could be abnormalities of tissue that would be in a field of radiation, particularly if it's during a younger period where there might still be some growth. There is development in terms of intellectual function, social and emotional maturation, as well as sexual development and sexual functioning. Cancer and its treatment can really affect any organ system. If you had a transplant for a malignancy or were treated prior to transplant, you have all the effects of chemotherapy, radiation therapy, and surgery. Then you have the effects of the PrEP regimen from transplant, and then you have the effects of immune suppression. So it can obviously affect any organ system along the way. If you underwent a stem cell transplant for a non-malignant condition, then you have whatever complications you had from that disease walking into transplant, and often those complications don't magically go away, and you have whatever exposures you had to treatment for that primary disease before your transplant, and then you have obviously effects of PrEP regimen and immune suppression. And then, of course, you need to be monitored not only for recurrence of your cancer, but also for subsequent neoplasms that may occur as a result of genetics or the treatment that you received, and those could be either benign or malignant. So I'm just going to give a few examples, and this is not meant to be comprehensive at all. So if we think about the endocrine system, right, hormones and glands, you can have abnormalities because of central nervous system radiation, neck radiation, and gonadal radiation. For something, the metabolic syndrome is not uncommon after transplant, especially if you had TBI and then had a cranial boost and were on long-term corticosteroids, for example, graft versus host disease. And bone health, again, can be affected by decreased sun exposure because you're not getting vitamin D, CNS or bone radiation as part of TBI or a boost, and then again, corticosteroids. Fertility after cancer can certainly be affected. Obviously, if there was removal of reproductive organs or pelvic or spinal surgeries that affect pelvic nerves that feed reproductive organs. Obviously, in terms of radiation, if you receive total body irradiation, hypothalamus, pituitary gland are in the field of radiation and reproductive organs. So ovarian failure following stem cell transplant is clearly a risk, as well as if males infertility because of radiation to the testes. In addition, there are lots of chemotherapies that can affect radiation. Most of them fall into the alkylating agent family. So I've listed the common ones there, and the ones that you might see most commonly during transplant would be cyclophosphamide in a cyclophosphamide total body irradiation protocol, or melphalan if you receive, for example, an autologous transplant. So those can affect, so you really need to be followed by a gynecologist afterwards so you understand kind of what your fertility issues are and what your options are. Heart health is very important. So if you were treated with chemotherapy prior to your stem cell transplant with anthracyclines, so those would be medications such as doxorubicin, daunorubicin, monoxantrone, those in and of themselves, depending on the dose, And you can see there's a dose response curve here for the onset of a cardiomyopathy or congestive heart failure from these medications. If you were treated with platinum chemotherapy, cisplatin or carboplatin, either pre-transplant or something like carboplatin as part of a preparative regimen, you could have issues with hyperlipidemia and hypertension. If you were treated with immunotherapy, it can cause a myocarditis or an inflammation of the heart and muscle. And of course, if you receive total body irradiation or you receive chest radiation as part of a primary malignancy treatment and then subsequently had a transplant, again, that heart and vessels are in the field of that radiation and can undergo damage. Incidence of subsequent neoplasms is a clear issue. This was data a number of years ago from the Fred Hutchinson Cancer Research Center looking at the probability of a subsequent malignant cancer after stem cell transplant. And as you can see, at 25 years, the cumulative incidence was a little bit more than 20%. So you have, and there's specific screening that is different for transplant survivors than the general population for certain types of cancer that you might be at risk for by either genetics, your primary disease, or the treatment that you had. Another kind of cancer that is very common after transplant, and this was also data from the Fred Hutchinson a number of years ago, but it has not changed tremendously over that period of time, is the onset of skin and mucosal cancers. This is particularly troublesome in people who have chronic graft versus host disease for several reasons. One, the immune milieu and immune suppression, and two, this occurs in areas of lots of cell turnover, which happens if you have GVHD of either your skin or mucosal surfaces. And as you can see, at 25 years, the incidence, of squamous cell carcinoma was a little bit more than 5%, and for basal cell carcinoma, 8%. So patients should absolutely have, skin exams as part of follow-up, and if there's any kind of lesion, have that looked at very early so it's picked up and removed before it becomes problematic. The other thing that we have seen after stem cell transplant is an increased incidence of breast cancer. This has been clearly related to the use of total body irradiation during transplant, but also may be related to pre-transplant chemotherapy and or a genetic predisposition. I would be remiss if I didn't address the psychosocial effects of stem cell transplant. Obviously, stem cell transplant is far from a walk in the park. There's lots that goes on both prior to coming to transplant, during transplant, and for many years after transplant. And this just summarizes all of the issues that can be faced by transplant survivors. And the most important thing we tell our survivors here at Vanderbilt-Ingram is you really need to adjust to a new normal and not just think that right after your transplant you're going to bounce right back. Cognitive effects can occur. People call it chemo brain, but it can happen even without chemotherapy. And it's issues like memory acquisition, executive function, kind of planning and organizing, trial and error reasoning, complex attention, speed of information processing can be a problem, sustained attention and screening out distractions, and multitasking. And this is learning how to deal with this and be able to move forward in your life. Most survivors after treatment have good to excellent health by self-report, but physical impairments can have a major impact on function and quality of life in a true meaningful minority. 1 in 5 will have work limits up to 5 years later. About 50% of those continue working, and 8% never can work after having cancer treatment as a whole. It's very important that if you've been treated for cancer, that you receive a survivorship care plan. That should include the diagnostic information. It should include your treatment modalities, including pre-transplant treatment as well as transplant preparative regimen and kind of the doses of it, any important clinical events that happen during treatment or transplant, whether you receive transfusions, family history, summarizing cancer-related health risks, and risk-based screening. And I put this website up. This is Be the Match. And they have really nice post-transplant long-term follow-up care guidelines that can be helpful to you and to your physician in following you post-transplant. And they're actually put together kind of like in a PDF, and it's very, very easy to follow. It's very important post-transplant to practice good health promotion, regular primary care, keeping a healthy weight, physical activity, healthy eating, avoiding or certainly limiting alcohol use, avoiding all tobacco use, and undergoing cancer screening, not only recurrence of your original cancer, but remember, you're at risk for other cancers in the general population. So when you're at the right age, or have other risk factors, make sure that you're undergoing cancer screening for things like breast, colorectal, lung cancer, prostate cancer, cervical cancer, in addition to anything specific you might be at risk for because of your transplant. It is important to kind of have surveillance for late toxicities. This data comes from the Be the Match long-term follow-up guidelines. There are other long-term follow-up guidelines that are very, very similar. They may change in terms of frequency, et cetera, but give or take, these are the systems that you need to think about post-transplant, and these are the surveillance that kind of need to be done by your either primary care physician or your oncologist if you're still seeing them. So to conclude, survival post-transplant is clearly increasing, but survivors are at increased risk for adverse health-related outcomes. Special issues exist for patients who've had transplants, for non-malignant diseases that have to come into this as well. There's a need for integrated survivorship and primary care. Transition always remains a problem, kind of from the acute transplant phase to long-term care, as well as going from being followed for your stem cell transplant to primary care. So we need to continue to provide research and clinical care in this area. And with that, I thank you.
Thank you so much. And now we will have Terese Roob. Thanks, Terese.
Hi, thank you. Thank you so much for inviting me. I've so enjoyed these webinars myself and rewatched often many of them. So I appreciate being a part of one. I'm excited to be here because I hope that my story will connect with some of you and be as encouraging as I have found other survivor stories to be. And as you can see from this slide, throughout this experience, it's important for all of us to highlight the roles that we play in life, not just the one that comes at the end, our survivorship being that way. Our identities haven't changed. Only for those of us that have had an allo transplant, our DNA has. So waking up this morning, as usual, telling myself it's going to be a great day, I'm ready to share my story. I have lots of pictures on my slides. Being a teacher, having a visual component has always been a fun and important part of it. So I apologize if I don't get to the point of explaining all the pictures, but I think those of you that are in this boat can kind of recognize the pieces of the season that I hope to highlight. The first one is the diagnosis to transplant. When we have our story to share, often it starts with it being surreal because it comes from left field. I was a teacher, classroom teacher for 3rd grade, and I was hit pretty hard, pretty suddenly. For about a month, I self-diagnosed myself with a sinus infection. I had tachycardia and extreme fatigue for about 4 weeks, hoping it would pass. And it got to that point where some of us might find ourselves in the ER or in just an annual check, and we have that doctor step out and say, you know, you have leukemia, and had no idea. Had lots of testing. My diagnosis as atypical CML is very rare. My doctor has said that he comes across maybe 1 or 2. And so it was a pretty lonely season. They referred me right away to the Colorado Blood Cancer Institute. They are wonderful there. We have a lot of emotions, those of us in this season. Of course, in the beginning, going back to the beginning, our emotions are running high. And we're waiting for answers, and so we can fill in that blank of you scream, I scream, we all scream for, and typically it's not ice cream at this point. We really do have that, oh my goodness, what is happening? And personally, we leaned into the Lord. He is our strength and all-knowing and had control of it all, because we don't know what we don't know, and that's okay. We're not the doctors, and I appreciate Dr. Friedman's information, even at this point, because they really are the experts. And you've heard this 1,000 times, not to Google anything. Even at this later stage in survivorship, we cannot take it upon ourselves to kind of be that inquiry master. So making that list, checking with our doctors definitely keeps our mindset in a positive perspective. We have this rule of no WCS at our house. We cannot do worst case scenario talk. It just doesn't do anyone any good. We have to cross one bridge at a time. And funny, but beginning at the very beginning, my best advice I just held on to really strongly was to trust our doctors, and we trust God. But the idea that the doctors are in hematology have so much support, tumor board partners, all the things, listening to their advice and not following any kind of internet path. We all share a very common experience, but yet all very different. And so it's just not fair to ourselves and our health to try to explore on our own. So much of what we know is out of our control, so much of what we don't know. So taking control of what we can is really important and really helped us in the beginning. Just finding out what I can control, not comparing myself to other people, staying positive. We all find those things to either surround ourselves with positive, encouraging words, music, pictures, scripture, just taking the time to take that breath, pause, take in your peace, and we press on one day at a time. So the next season I'm highlighting is that season to survive, learning to do that from our transplant time until that end of 100 days, that acute phase that is so critical to the next steps. And you'll notice a lot of my pictures, I'm pretty vulnerable in these pictures. I find it very helpful when I can share a story with someone who also experiences the same sadness, the same things. And of course, it's a season, so it comes and it goes, but yet we have kind of that common bond. And maybe everyone got that 2-inch binder like I did about the germs and the rules and, oh my gosh, all the rules, the masks, the gloves, all the things. It can be so lonely and isolating. My husband and I just really put a bubble around ourselves, and people wanted so to help. And so we tried to push that fear aside and let people help. It can be such a blessing for those around us to reach in. So we had to put our pride aside and realize that it was just as helpful for them to step in as it is for us to accept that help. As a teacher, I do a lot of acronyms, and so FIGHT was a big one that we used in the beginning, fully integrate good healing today. So trying to just keep on keeping on. GVHD is a thing. It's manageable. The doctors know all kinds of things that are options for us. And at the beginning, for me, it was pretty tough in the hospital. And shortly after, thankfully, at this point, things are starting to settle down. But I knew, again, I could control two things. One was keeping my body hydrated, drinking lots and lots of water. The doctors were very happy that I was able to do that for all my organ health, and breathing deep, keeping my lungs at capacity. We know that atrophy can happen so very fast. So anything they tell us to do to be a good patient, I felt like was important. All things Dr. Friedman brought up about seeing this doctor versus that doctor and that doctor. We are now almost with an honorary degree, right, of these doctor degrees for our own body, but it's so important to catch things early. And making sure to eat something. You know, they told me even eat ice cream if I could, but whatever, calories counted. And washing our hands like crazy. You know, I think that being a good patient is really the best we can do for ourselves. And it's okay to not be okay. It kind of speaks for itself. I'm a huge proponent of therapy, all the things for mental health. Our mind guides our body in so many ways. So having to ride that wave, give yourself some grace, give yourself a break. It's good for your health because this too shall pass. Focusing on that gratitude, hidden blessings every day. And again, work as hard for your body health. Work on your mind health as strong as you can, your body health. Our mind is strong. However, our bodies are way stronger than we think they are. They're incredible machines. The fact that we were blessed with this miracle with stem cells or even our own cells, if you had an auto, it's getting better every day as we're learning the medical technology and science of it all. We're walking miracles. It's fascinating. So again, pause, breathe in your peace, and press on. Learning to listen. You know, listening to our bodies, it's kind of a new thing. We used to, but now it becomes much more important. So that phase from that 100 days to the 1 year milestone, you know, staying the course. If things are going well, keep on keeping on in that way. And our family, even when I was feeling good, they really wanted to stretch the boundaries. I had a new grandbaby. Come and do this with us, Mom. You know, we want to do that. And I just had to be careful to stay within the boundaries because so far so good was happening, even though we had to make some changes. I had my first artificial tree in like 40 years. It was heartbreaking that I couldn't have my plants and, you know, all those things. But we made it work and we stayed the course. And for that, I was able to spend time with friends and see my grandbaby's first Christmas with Santa and celebrate a birthday. And, you know, just we have to be able to listen to those boundaries and parameters with some grace. And listening to our body has a lot to do with it. When we have that ache or we have that pain too, not blowing it up into a mountain. I tried to keep so many things small until I needed to make it that mountain and call that doctor or have a concern. I don't want to say worry, but yes, of course we have worries. But try as I might, all of us, you know, sometimes we say my husband can be that worst case scenario voice, which is very helpful in some critical situations, definitely. But we really worked hard to just take one step at a time. And early detection, again, like Dr. Friedman said, is so important. So feeding that beast, you know, as a teacher, we read folktales to our kids. And you know the one about the wolf, the one you feed will grow and win. So we made it a point to feed that positive mindset again. And again, with the body, the immune boosting nutrition and antioxidants. And I tried to key into any kind of information resource that gave me a proactive approach. Of course, not everything worked for me or applied to me, but I took away what I heard in a trend form across many different websites, which I'll share at the end. But taking good care of our mind with that positive mindset, our body with good food, excuse me, and nutrition, and our soul with meditation and prayer and balance and peace, and all of that is so so much a great formula for success. Reading less about my cancer, and I read more things about a healthy lifestyle and habits and enjoyable things. It helped me to stay ahead of it. This little vision board picture next to the Christmas tree, my therapist recommended, and it was pretty overwhelming for me to think about. When we get that diagnosis, it's usually from left field, and I can't plan that far ahead. And so one recommendation she gave me was just think about the next 3 months. Put it into a time frame where I could really, and you probably can't see, but each one of those boxes of that door that I chose focused in on each month. I chose the 3 months and what was my end result, that I really wanted to achieve. So that was really important, staying up on my appointments, keeping my lists. Again, I'm a control freak a little bit, so I make a lot of lists, do a lot of planning, just knowing that I can change those plans if need be. Seeking that comfort, words of wisdom. So many survivors are out there, thank God. We really have come to that other side. So for that, I'm so, so grateful. But you've got to choose your place of comfort. What is it that will bring you that hope, and focusing on the hope? And the thought is, yes, that's all we need is hope. But I'm a Beatles fan, so I had to say that, love too. We have to love others. And so being a person who wants to find that joy every day, anticipating it, because then I will be pleasantly surprised, and knowing that I won't always feel happy, but that joy inside of us for everyone is a little bit different, but making sure that the focus of that joy is within, and don't let anyone steal it from you. So the next season is the season to learning to thrive, year one and beyond. Leaning in, finding those key resources that really feed your beast, right? Positive and encouraging ones. And just like Dr. Friedman said, anxiety and depression, that mental health is still a thing, and it may not be full-on anxiety or full-on depression, but I've had lots of days of sadness and lots of days of anxiety, and it'll come, and I let it like a breeze just come in, and I feel it. I don't try to stuff it. I don't try to push it aside. I allow myself to feel it and let it go, and it will go, which, a lot of things that I've tried to do across the years have really come into practice during this type of season. As you know, we all go through this not knowing what to expect. So again, I highly recommend leaning in and watching, listening, re-watching, re-listening. There's so many encouraging speakers out there, and even on this on our platform right now with NBMT Link, so many things I have watched and rewatched just because my season has been different as I go through this journey. And as we know, I'm repeating a lot of things that a lot of people have heard. However, as a teacher, I know that we typically have to have a repetition for things to sink in, and sometimes up to 7 times for new info. And I love to learn. So if I hear it from one person, I know if I hear the same thing from someone else, I may hear it in a different way, or I'm in a different space, and it's really, really helpful. So knowing that today is one day, and taking one day at a time, we can handle anything. We don't have to take on 3 months of whatever might come up. We think about today, and I know that when the sun goes down tonight, we will at least make a step forward in the right direction. So the new me, as we all are talking about this new normal, how many times throughout this year, or even for some of us longer, we've said we can't do that, or we won't do that, or I really would like to, but I can't. We need to flip that story and just know that change is good. And now there are things that I can do and things that I will do and that I want to do. And I've learned that anyone who thinks that they'll always be or do what they've always done truly is foolish. And change is a part of life. So embracing that new now and flipping our story so that things are now I can and I will. And look at all the new people we've met and all the new experiences we've had. I mean, what a blessing and opportunity all wrapped in one. And we still, I know, for myself, having upcoming appointments, things like that can sometimes trigger these emotions that I don't necessarily enjoy experiencing, but just even expecting them, that they're going to come, and then afterwards saying, well, that wasn't so bad. Look, that turned out pretty well, and revisiting and reflecting on the good that comes out of some of those experiences definitely helps my mindset as I move forward with anticipating the next one, knowing that, again, today is one day. I will take it one day at a time. So we're all different, and we don't ever want to compare ourselves to each other, even though we do have some similarities. But again, your doctor is your best resource. And letting this experience that we're all having be a gift, not a curse. And so many good things I know have come out of it. Like I said, the people I've met, experiences I've had, wins that I've had that I never really knew that I could win unless we go through something difficult like this, and focusing on our gratitude. And I know we all talk about that's really the key to longevity, and having that positive mindset of gratitude. It's absolutely true. You know, it's proven to be healthy for our body and our mind. And as I lay my head down each night, I think about my day so that I go to sleep thinking of just positive things that have happened during the day, no matter what. And that's been really helpful. My story, I know, is not finished, as everyone else's who's listening, but, you know, I tend to want to grab that pen and finish that story, but I need to, and I'm working on this currently, is just to let it be the season that it is, and continue to be patient as a patient, because our healing definitely takes time. And these are all my family pictures, and, you know, you can kind of see, just we celebrated my little grandson's 1-year birthday at Build-A-Bear. Just a plug, they charge you only the amount that your child is aged. So that bear was $1, but we had a good time. So anyway, I love my family so much, and our special friends. You see a lot of friends in there playing pickleball and things like that. And my last slide, just learning to fly, the last of it. The rest of our life, open-ended, definitely lots of living yet to come. I'm so excited to connect with my German donor. I think I have to wait 2 years, which will be this coming May. I would love to have a connection with her. I'm so blessed to have a new life with a 2-year prognosis at the very beginning of all this, and I'm approaching my 2nd year. You know, I just feel like, you know, there's so much coming up. I have a wedding potentially coming up, more grandbabies, and as an educator, I'm excited to get back to the classroom or in some capacity teaching. I love the kids and I miss them and all of that. So I have lots to look forward to. So I think we all have lots to look forward to, and setting goals is very healthy for our mind and our body. Have a wellness vision, have self-care goals and nutrition and strength training and sleep, of course. Those are good goals to have. And again, it's a miracle that we're all living and surviving. So I just want to, again, honor the body that I have right now and take good care of it. So knowing our boundaries, knowing our capacity and limits, no is a complete sentence. And enough said. You do not have to explain why you can't attend this or meet that friend or, you know, stay up late and do something. It's fine to say no. And I've used it quite a bit. And really, our friends and family are so respectful, and they just love us so much, they're okay with that. And embracing that new normal every day, I've talked a lot about, but give yourself grace and space to ride the wave. You know, things that are different. Things that are different in our life. I'm sorry, slides are moving and I'm not moving them. But I wanted to make sure you could see even all the links on the right-hand side, things that I have accessed and have found super helpful as I speak. But, you know, blooming where you're planted, because, you know, you're here for a reason and you're still here for a reason. And so your impact on others may be seen or not seen. You're absolutely a gift. We all are. And we have a purpose every day. And, you know, setting up that mindset in the early morning of what my day will bring, I know a lot of us want to keep it open-ended, but still we have a purpose and we can always be a blessing to other people. And I heard this one, which again, you may have heard before, but your attitude determines your altitude. And here I live in Colorado with a mile-high city. However, I totally agree that what is our alternative? We can have a negative attitude, but it doesn't bring us any good. So thinking only positively and knowing that no matter what, even the uncomfortable things and the painful things all work together for the good. So lastly, stay faithful, stay hopeful, stay joyful, and keep smiling and breathe. Thank you very much for having me.
Thank you so much, Terese. Wonderful presentation. And now we have Dr. Carrie Kitko. Thank you so much for joining us, Dr. Kitko.
Thank you so much for having me today. So I am going to move on to talk specifically about a complication that happens post-transplant called chronic graft-versus-host disease. So again, we're going to talk a little bit about what is the initial treatment for that. Do we have some other agents that we can use if that first treatment doesn't work? A little bit about how we try and pick what drug we use and when. And again, because our focus is on survivorship, discussing a bit of the long-term impact of having chronic graft-versus-host disease. So chronic GVHD. So again, this does apply just to our allogeneic recipients out there. But this can be a really impactful complication that many of our patients experience, and it can go on for quite a bit. So I thought it was worth having a chunk of time on today's call to talk about this. And chronic GVHD can affect almost half of the recipients of an allogeneic transplant. And less than 20% are going to achieve a complete remission or partial remission without needing a second therapy within the first year after they were initially diagnosed with their chronic graft-versus-host disease. Most patients will require years of treatment. The average length of time that patients require immune suppression for chronic GVHD is around 2 to 3 years. The good news piece is that we do now have 3 FDA-approved agents available for second-line treatment of chronic GVHD, and I will go over each of these in a little bit more detail, but they're ibrutinib, ruxolitinib, and belumosudil. And again, chronic GVHD is important to recognize because of the morbidity and mortality that patients experience from this disorder, especially if they need a second or further line of therapy, remains high. And the patients that I worry about the most are those patients that have sclerosis or lung involvement, which have traditionally been the most difficult manifestations to treat. And the development of new and novel agents to treat chronic GVHD still remains an unmet need. So this slide just sort of represents how diffuse chronic GVHD can be and how it can look very different in any given patient that I'm seeing. So on the right side of the screen are sort of the 8 commonly diagnosed organs involved with chronic GVHD, which include the eyes, the mouth, the lungs, the gut, the urinary tract, the skin, the muscles. But there's also a lot of atypical manifestations that we're starting to be able to recognize more consistently that are also important to be aware of. Things like kidney involvement, some immune cytopenias that we sometimes see as well. But chronic GVHD, the bottom line is it's a complex disease. It can look very different from patient to patient, and even trying to figure out what the right treatment is for any given patient remains a challenge. So what are our goals when we're trying to treat chronic GVHD? Well, first is to control the signs and symptoms. And one of the questions that I often have to ask my patients are, how bothersome are those symptoms? If you're just having a little bit of mild dry eyes and maybe you're a little bit more thirsty, your mouth is a bit more dry, I mean, maybe you're somebody that I can get away with just, putting some wetting drops in your eyes more frequently and making sure that you're able to always have a water bottle with you. Maybe I don't even need to go ahead and start any new additional medications for something like that. But if patients are really impacting their daily activities because of their symptoms, then that's probably somebody I do need to start more aggressive treatment for. So I think the other important key is that when we see this chronic GVHD, trying to recognize, is this disease stable, or do I think that there is ongoing inflammation and organ damage happening? And if so, again, that's probably somebody I need to continue to leave or start treatment for their GVHD. I do want to try and keep in mind, though, what are the side effects of all these different drugs that we're considering to use and minimizing the toxicity if at all possible. I will talk a little bit more about steroids, but steroids tend to be our frontline treatment for this, but they have lots of side effects. So sometimes even if a patient is starting to get better on steroids, I might think about another agent so I can get them on a lower dose of steroids with less side effects. Some people worry, because maybe you remember back to your initial transplant consultation where we talked about graft versus leukemia or lymphoma versus the graft versus host disease effect. So some patients, can get nervous. Well, if you're treating my GVHD too aggressively, is that going to increase my risk of relapse? And there's really no evidence that once a patient develops moderate to severe chronic GVHD, that treatment increases their relapse risk. So if I'm worried about ongoing organ damage, it's important to go ahead and start treatment and hopefully rest assured that treatment is not increasing your chance of relapse of the underlying reason that you went through the transplant for. My goal is to try and get my patient's immune system and their body to get along, or what we call tolerance. And once we achieve that tolerance, then to be able to stop their immune suppression altogether. Sometimes it's figuring out the right mechanism of action, how the drug works for the particular manifestations, and sometimes just being patient. Maybe you're improving, but it's really slowly, and we'd like to see it improve more quickly, but maybe we just should, take a step back and let time do its thing. And then again, because patients do have some morbidity and mortality associated with chronic graft versus host disease, what can we do to decrease that mortality and increase survival? Most deaths that we see in patients that have chronic GVHD are still, unfortunately, there are some relapses, but infections, respiratory failure, and secondary cancers are also really important to be monitoring for. So as I mentioned, the first-line treatment for chronic graft versus host disease is corticosteroids, or prednisone is probably what you might know it as. And the textbooks would tell us that we should be treating with a dose of 1 milligram per kilogram per day. There's no significant benefit to adding a second agent up front. There have been several studies that have actually tried to look at doing this at promising drugs. Why don't we add steroids plus that drug that seems to work for GVHD that's resistant to steroids, but it doesn't seem to improve that overall response rate. So most physicians will just follow that textbook and start the steroids. Not always at that dose. There's lots of factors that go into deciding what dose, and if you already have other infectious complications or you've had issues with your bone health or a variety of other reasons, we might choose to start a lower steroid dose because, again, we're trying to look at that overall toxicity profile. Unfortunately, even starting steroids, there's usually only about a 40 to 50% response rate. And more than 50% of patients are going to require a second line of therapy within 1 to 2 years. Steroids work, but they're very broadly immunosuppressive. They're not what we call targeted. And because of that, you're really increasing a patient's risk of infection because you're not sort of pinpointing the immune cells that are causing the problem. And the side effects of steroids are really abundant. I'm sure if you're on this call and have chronic GVHD, you can chime in with your own list of these things. But things I worry about are infections, myopathy, which is like muscle weakening, swelling or edema, cataracts, high blood sugars, again, that bone density loss, in some of our younger patients, avascular necrosis, and sleep and mood disturbances are also quite common as well. So this is just looking at some of that real-life data about how do we treat our patients. Again, I told you that textbook said to start prednisone, and typically at a dose of 1 milligram per kilogram. And the chronic GVHD community has a large consortium that was able to look and see what did we really do. And you can see that in the end, it really didn't matter. About half of the patients did follow the textbook and get started on steroids alone. About a quarter of the patients got started on steroids plus something else. And then about 20% of the patients got started on something besides steroids, so a non-prednisone option. And at the end of the day, the failure-free survival, so that means that the patient is still alive and didn't need to go on something else for their chronic GVHD. So every time this bar is dropping, it means that they failed steroids and decided to add something else. And you can see it really didn't matter so much on why, on what you got started initially. And that might make you feel good or bad, but I guess it gives me comfort as a physician that I can think about things like that toxicity profile of the patient sitting in front of me and not use a one-size-fits-all approach. And at the end of the day, the overall survival and response rates seem pretty similar. So there are guidelines. So the National Cancer Institute has made some guidelines about steroid refractory chronic GVHD. And so there's this list that they provide of drugs that have been used and have shown some response in chronic GVHD. And because chronic GVHD is so complex, it took the FDA a while to really get on board with our response criteria in order to actually give FDA approval to some of these agents. So as I mentioned, the ibrutinib, ruxolitinib, and belumosudil, these ones that are here in bold, are the ones that are FDA approved. Now, that doesn't mean that we can't use some of these other things on this list because they have a good track record. It just means that we use some of these drugs in an age before the FDA started giving FDA approval for some of these treatments. So again, there is a nice big list here of things that we can try. So, trying to stay encouraged that if the first thing that your doc pulls out of the hat to try for your chronic GVHD, if it doesn't work, we have other options that we are going to be able to go to as well. So I am going to focus just a bit on those 3 FDA-approved agents and let you know why we are excited about them. So the first was ibrutinib that was studied for steroid refractory chronic GVHD. It was a pretty small study initially at what we call a phase 1B and 2 design. For this study in particular, they were very specific on the type of chronic GVHD manifestations that you had to have. The first was that you had to have skin involvement with a red rash. And the other possible criteria, you could have one or the other, was that you had mouth symptoms. And again, part of this was driven by being able to prove to the FDA that we could demonstrate a response. And these were sort of easy organs to be able to document a response. So that's how this study was designed. And they used ibrutinib, which is an oral medicine that the patients were able to take once a day. And the primary endpoint, or how we decided if the drug was working, was the percentage of patients that had a response according to the commonly used criteria in the transplant world, these NIH consensus criteria. And we were able to show that, yes, in fact, a little over 60% of patients did have a complete or partial response. The majority are partial responses. So again, that's something really important with chronic GVHD. We think a lot of what's happening is that there's some underlying fibrosis or scarring that's happening, and it can be hard to reverse that. You definitely, progress for some people is not seeing any further involvement of the amount of skin that's involved or any further decline in somebody's pulmonary function studies. But sometimes we get lucky and some patients do actually have a complete response. So that's still a goal, but partial responses are much more common. And then the graph on the right just shows that when they asked both the doctor and the patient, there were response that both groups felt like patients were getting better with this drug. So then what about ruxolitinib? So I think this was a really exciting study. So this study looked at, was what we call a randomized trial. So patients either got ruxolitinib, which is the drug that they were studying, or they still wanted to say for those patients not responding to steroids, we didn't want to give them a placebo. We wanted to give them something. So the study had a list of about 7 or 8 very commonly used chronic GVHD treatments, sort of like from that table I had a few slides back. So if you didn't get ruxolitinib, you got a drug that your physician felt very comfortable using instead. And they showed a significant difference in the amount of responses. So around 50% of patients responded got ruxolitinib versus only 25% if they got what was considered a best available treatment. And then the Lee symptom scale is a scale that we can use that we give our patients. So I think about it as an overall symptom burden. And improvements in that have been shown to be clinically meaningful. And about a quarter of the patients on ruxolitinib had an improvement in their Lee symptom scale, whereas only about 11% that got the best available therapy. And you can see, again, failure-free survival, so the need to pull the trigger on another treatment was significantly improved. So the patients that got started on ruxolitinib were able to continue on ruxolitinib because they were continuing to improve, versus those on best available therapy were much more likely to go on and need the second agent, or a third agent at that point, really. And then the third study, or the third drug, I should say, is belimostimil, also known as KD025. And this was another phase 2 study. These patients had to have failed at least 2 to 5 lines of therapy. So these were actually pretty heavily pretreated patients in this study, and still had a very great overall response rate of just over 70%. What the study randomized to was whether or not the drug could be given once a day versus twice a day, and they didn't see a difference between that. So most patients will only get the drug once a day and be expected to have that 73% overall response rate. And again, this sort of median duration of response, that failure-free survival of 50 weeks, is also very encouraging, that you're not needing to go to a next line of therapy quite as often. And this just shows then sort of broken down by individual organs, which organs were more or less likely to respond. Again, lots of partial responses and some complete responses. This table can be, or this tree, I should say, can be a little bit confusing, but I think the take-home point was that they broke down the patients that they were treating and really found that most patients were responding, and it didn't matter as much if you were treated earlier in the disease or late in the disease, or it didn't matter if you previously received ibrutinib or had not received ibrutinib. And so I think, again, that's encouraging, at least for me as a physician, that, you know, when I'm sitting down and talking about side effect profiles, if I try one first and you didn't respond well, I could still use belimostimil later, and I didn't miss my opportunity. So this is, I think, one of the frustrating pieces, I know for me as a physician, and I'm sure worse as a patient, is what drug to use and when. So our current strategies really rely on the availability of clinical trials and physician preference, which is really, you know, trial and error. You know, you want your, to feel confident that you understand the side effect profile, you understand the drugs that the new agent might interact with, and so you definitely have preference about which drugs you feel the most confident using and therefore recommending to your patients. And that can be frustrating because maybe it worked for the first patient I saw on the day, but the patient I saw later in the day seemed very similar and didn't have a response rate. And we don't have a great way right now to predict that ahead of time, unfortunately. And all steroid refractory chronic GVHD is not the same. The ideal state that I can tell you that we are absolutely trying to work for is a biologically driven selection. So something, that we could test perhaps in the patient's blood that would indicate this pathway is really activated, so this drug would be good, or we know that patients that have this elevation are the ones more likely to respond, or even biomarkers to help us sort of predict early on if, A is elevated at the start and a month later that level is lower. Those are the patients that tended to respond, and so we should keep going even if you don't feel a significant change, maybe only 4 weeks into that new treatment. So we're working on all of those things, but we're not quite ready for prime time with that. So again, what are some other things that I think we really need to worry about with our patients with chronic GVHD? I still think we really need to focus on quality of life and function. How are you feeling? How are you getting about and able to get up and move around? What are your GVHD specific symptoms, and are there supportive cares that I could be doing to help offset that? Things to help with mouth dryness that might not be a GVHD specific treatment, but things that I can add that help maybe increase saliva production as an example. These medicines are expensive, and patients with severe chronic GVHD can't always go back to work. So making sure that, that we're keeping up with our social work and making sure that, any resources that families might need that we're able to help provide. This does cause a lot of psychological stress as well. So making sure that I'm screening regularly for things like anxiety and depression in my patients is really important. And then being able to plug them into hopefully either a social worker or a psychologist that might be able to help with that, I think is really critical. And I think thinking about chronic GVHD as a multi-system disease and needing additional partners is also really important. So I have like my go-to pulmonologist and dermatologist that I can go to for help with challenging patients is really important as well. And then just other supportive things like thinking about nutrition, thinking about physical therapy, thinking about occupational therapy. I think those pieces are also super important, as hopefully we are finding the right drug to get you feeling better. If you're having difficulty with skin tightness, joint tightness, having physical therapy on board as things are maybe softening up is going to help that process go even better. So working with my colleagues in other areas outside of transplant specifically, I think is still really important for our patients. And then again, thinking about that sort of long-term, the GVHD-induced organ damage, so things like ongoing immune deficiency, cataracts, kidneys can also be impacted, less commonly directly from the GVHD, but from the drugs that I'm giving sometimes. Again, steroids have lots of side effects, and so things like diabetes, dyslipidemia, the myopathies, adrenal insufficiency, osteoporosis are very important to be mindful of and be managing. Osteoporosis, as I just mentioned, neuropathy we can sometimes see, and this is multifactorial, can sometimes be from the drugs that we gave to treat the GVHD, and sometimes I think because of how patients get a particular kind of skin involvement, we can also see neuropathy from that as well. And again, monitoring for the secondary malignancies, getting patients plugged into dermatology, particularly if they've had history of chronic graft-versus-host disease of the skin, to assess their skin on a regular basis is also really important. And I think that's all I had.
Thank you so much, Dr. Kitko. Wonderful presentation. I'm going to try to move through mine and make sure we have at least time for a question or two. But I am so thankful we have had 3 amazing speakers. So tips for coping with fatigue. First of all, fatigue is one of the most common side effects that anyone with cancer can get. If you look at the National Comprehensive Cancer Network, they have a set of guidelines that you can look at and get ideas on how to work on your fatigue. But the highlight is fatigue is when you feel very tired or exhausted most or all of the time. 9 out of 10 people get it, and it affects everyone different. It's on a spectrum. But the important difference between someone who's just tired and fatigue is this is the kind of thing that doesn't go away with rest. And then, of course, how much does that interrupt your function? So that's what we talk about when we talk about fatigue. You may experience fatigue if cancer treatment damages healthy cells in addition to the cancer cells. Or fatigue might happen as your body works to repair the damage caused by treatment. Some treatment side effects such as anemia, nausea, vomiting, pain, insomnia, changes in mood, and they can all cause issues with fatigue. So getting treated for medical conditions or causes that might make your fatigue worse. First of all, always tell your healthcare team about your fatigue. I know so many people are like, oh, I don't want to whine, they're doing everything they can, but sometimes there might be some things that we can look at. For example, pain or its treatment, especially pain medication. There might be some tweaks that could be made, like maybe talking to a nutritionist about an anti-inflammatory diet, or maybe trying some tricyclics that can help pain and depression, or glucosamine, or acupuncture even. Acupuncture actually is recognized by the World Health Organization for about 30 different diseases that it says it could help with. So things like that could be suggested. Emotional distress, such as anxiety or depression, that absolutely can add to that sense of just not wanting to get out of bed. And I will tell you, when I've ran support groups, about 2/3 of the people in the support groups admit to asking their doctors to assist with some kind of medication because of anxiety and depression. So don't be ashamed. Don't let it be a stigma. This is all part of the journey. You are mind, body, and spirit, and so we want to make sure all parts of you get better. Poor nutrition or electrolyte imbalances such as abnormal levels of potassium, calcium, magnesium, anemia, which is an abnormally low level of red blood cells, sleep disturbances, such as sleep apnea or restless leg syndrome, medication side effects, or other medical conditions such as heart, lung, or hormonal problems. So here's some tips. It's important to focus on what we can change when managing fatigue. Some things we can't, like we can't change a diagnosis, we can't change treatment paths or getting older, but we can certainly try to look for what is in our control. Again, we can try to change pain management, how we're coping, nutrition, and management of other health issues. Also, just as Dr. Friedman said, sugar and excess carbs, such as those found in alcohol, can make sugar levels spike and plummet, which can also make fatigue worse. So it's important to learn your limits with your energy and try not to overdo it too much. You want to steadily grow in your endurance, but going beyond your limits one day can cause great consequences the next days. In the beginning especially, I've had patients tell me stories about falling asleep in a bathtub, but that same patient that I'm thinking of right now, he was running a marathon within 4 years of his transplant. That's not everybody's story, but little bits and little pieces building up your strength, you'd be amazed where you can go. Exercise is highly recommended to those with fatigue, as that building back muscle can increase your energy. It also can increase your mood, your memory, and of course, keeping a healthy body mass index is important too. You can start really small, perhaps 5 minutes a day, or by starting with physical therapy. Live Strong and the YMCA have developed a great program for cancer patients. You could ask your doctor for a referral to physical therapy, occupational therapy. There's also a fun little thing if you need motivation. One of our patients had shared with us that he does something called, it is the, oh, forgive me, I am blanking at the moment, the Charity Miles, thank you. Charity Miles, and that you can make donations based on how much you're walking. So let's say you want to raise some money for the Leukemia Foundation. If that is one of the charities on there, you can walk and make those steps count towards helping with your organization, and that can motivate you. So little tips to bring that exercise up. 30 minutes a day, as recommended for many adults, might, again, not be where you start, but you do a little bit at a time. Again, another patient of ours told us how every day she started with trying to find something to make herself feel physically stronger, emotionally, mentally stronger. Like maybe in the beginning, it was just noticing that she felt stronger when she sat in a chair versus the hospital bed. And so she would push herself each day to go a little further in that chair. So little things like that. Relaxation, mindfulness, cognitive behavioral therapy can improve quality of life and help people cope better. Some people also do better, again, with medications for anxiety or depression. It might sound a little cliche, but perception really can make a difference. I know we had someone tell us how he and his wife kept getting so frustrated that they just wanted her to get better. But eventually, instead of just going for just trying to be the old her, which isn't really something that you set your goals on, you try to figure out who you are after transplant, they set little markers so that they got achievements that they could celebrate. Like, when was she able to hold their grandchild again, instead of when am I totally better? Another thing is it's important to eat enough protein and healthy fats to promote healing. And of course, keeping hydrated, drinking those 8-ounce glasses of water a day. It helps all those organs. Practice good sleep hygiene. Don't watch TV or play on screens 30 minutes before bed or sleep. Make sure, that your bed is only for sleep or being intimate, because other activities in the bed can help that brain just be more stimulated and have a hard time making it fall asleep. You can also talk to your doctor about sleep apnea studies if that's suspected. Some survivorship clinics are writing prescriptions for Ritalin or a methylphenidate on occasion to help patients with energy issues. You know, some of the studies show that everyday use doesn't have the same effect, but let's say you know you have a wedding coming up or a day that's really special in your family. You could talk to your doctor about whether they feel that is an option for you based on your overall health conditions. Another option is light therapy. Dr. William Redd has some great research out where he was testing patients with bright white lights half hour in the morning. These are simple little like iPads that you can get on Amazon. The importance is to get the white light to the back of the eye so that it does the most work, but 30 minutes a day of that was helping people with fatigue. Fatigue is challenging and it's important to plan ahead. So ask for help and prioritize what you need done. And just a couple survivors here, Meredith, who of the Meredith Cowden Foundation, they do so much great work with GVHD awareness and research, but her tips were discover what time of day your body's at its peak and try to schedule what you need to do during those times. So like if you know mornings are really tough for you, try to make those appointments in the afternoon. Allow yourself breaks and try to break bigger tasks into smaller tasks. She also talks about how she does ginseng tea. Mayo did a study a while back, and 2 grams a day for about 8 weeks showed improvements with fatigue. So again, you can discuss these things with your doctor. If it seems like something you want to try, it's worth a try. David, another person who's been just so wonderful at the link, he said he found it helpful to be social, even on the transplant floor. Like if he did a lap, he would try to say hi to people. It just helped his overall outlook. He has really noticed how high-quality food instead of junk food has really made a difference in his long-term survival. And when able, he gets involved to give back to others. He says fatigue is no joke. Get the rest you require, and it helps you get more done. Because a lot of people will tell us how if you overdo it, it might take you down for another day or two. And so it's learning how to pace yourself and reading what your body says. But this is also a little quote for you all just to try to inspire you. These notes will all be on our website too. Within a week, this recording of this webinar will be on there and you can print these off. But the highlights are, you have value no matter what you are doing. If you're exhausted, let yourself rest. If you don't feel like starting a new project, you don't have to. Just read your body, listen to it, and do the best you can with each day. So now we would like to go to questions. And I know we only have so much time left, but I'm going to start with the first one. And we have the pleasure of having 2 doctors on the call. So I will probably just toggle back and forth between you 2. But if anyone wants to chime in after the other has spoke, please feel free to do so. I have one person that writes, I had an allogeneic BNT 2 years ago with a 12 out of 12 HLA match with my donor as well as the same blood type. Why do I have GVHD issues? And maybe I'll send that one to Dr. Kitko if I could.
Yes, I'm happy to try and tackle that one. So we know that HLA matching is definitely the biggest risk factor in terms of development of acute and chronic graft versus host disease. But they're not the only factors. There are other what we consider minor histocompatibility antigens that are also at play in the development of graft versus host disease. And so even though somebody is perfectly matched at the HLA loci that we know how to test for, there are very likely to be differences in these minor histocompatibility antigens that aren't as easy to test or match for. And so this is why even a perfectly matched brother or sister also has a risk of graft versus host disease as well. So it's our best way of reducing that risk, but unfortunately it does not bring that risk to zero.
Thank you so much. Dr. Friedman, one person had asked, with screenings, how often should those happen? Like this person talks about, screening for chronic GVHD or skin checks or any of those things that they're more susceptible to.
That's a good question. So some of it depends on individual risk, but at a minimum, we recommend that, and that survivors should be seen. And a lot of it depends, right? If they have chronic GVHD, they're going to be followed much more closely, and they're going to be followed for a long time. But let's take the survivor who does not have chronic GVHD, who doesn't have any active transplant issues, and so what we recommend is that they're seen by a healthcare provider at least twice a year. In addition to any specific transplant-related follow-up, but at least twice a year, or for screening for any kinds of long-term effects from their transplant. But again, very, very individualized, because if they have chronic graft versus host disease, or they're at risk of losing their graft, or they're having some symptoms of recurrence, or they're at very high risk for recurrence, any of those kinds of things, then that frequency would be very much considered.
Thank you so much. Terese, you have quite a fan club on here. Do you have a preference, if anyone had any specific questions for you after? I know that you tried to reach out to a few people on here. Would it be possible for, if someone sent us an email, for you to answer, that they could send an email to myself or Peg and we could forward it to you?
That would be great. I would love that, for sure.
Okay, great. So if any of Teresa's fan club wants to reach out to Peggy or I, well, you were quite
we're all part of the club, I guess.
So, well, it's so great to not feel alone in this, and you had some wonderful insight, and your attitude is absolutely amazing. So yes, for any of the Teresa people, feel free to reach out to myself, Jennifer Gillette, at JENNIFER, Gillette, just like my name on the screen, which is GILLETTE, at nbmtlink.org. And if that was way too fast for you, if you go to our website at nbmtlink.org, you can always reach out to us that way, and we'll do our best for you. There was one other question I wanted to address before we ended today. Someone wrote, just yesterday I asked my husband if he was still in love with me. I told him I know he loves me, but I was wondering if it's common for the spouse to become a caregiver and not a partner, if that makes sense. And the one thing I wanted to say to this person, and Teresa, if you have any thoughts, or the doctors, I'm open to hear that too, is, when we go through this, it affects every part of our being. Your relationship with your spouse is a part of your being. They take on a big hat of being caregiver, and sometimes it can be a transition to try to go back to being a couple instead of a caregiver and a patient. It doesn't mean that your marriage can't make it. It might mean that maybe you need a little help overcoming those things. If you go to the BMT InfoNet website, they have done a great job trying to make a place where you can find people that specialize in what you need. It might be someone like a doctor who specializes in GVHD that's in your state. Or it also might be a therapist who understands those issues of how do you help couples work through that phase of transition from caregiver back to the couple, or even just understanding all these survivorship issues. That is truly a specialty. So I encourage you to try to find a therapist if that is an issue for you, and see if they can help you and your husband rebuild. But on that note, I would like to thank everyone for being here today. Amazing presentations, and I hope everyone got something from this today. We hope you have a great day. We thank our sponsors. We thank our link partners. And if there's anything else we can do to support you, please reach out.
Thank you. That does conclude today's webcast. You may disconnect your line at this time and have a wonderful day. We thank you for your participation today.